So, so this is the webinar being presented by Academy of Pain Physiatrists exclusively to its members. So today we are going to discuss on some very important topic, that is the headache. Headaches, as we all know, it is one of the most prevalent neurological disorder. About half of all adults worldwide, at least they suffer from this headache once a year. And it is the third leading cause of years lost to disability as per the Global Burden of Diseases 2021. If we talk about India, there are some studies which shows that overall prevalence of headache was 63.9% over the course of a year, and it was higher in women and people in rural areas. So as a pain specialist, we need to know about the various aspects of headaches and their management. So today we have our esteemed speaker with us, Dr. Dhruv Bibra, sir. So he's a very renowned senior consultant in pain medicine practicing at Delhi Pain Management Center, New Delhi. He is currently managing 3 centers of DPMC in Delhi NCR area, along with visiting consultant services at multiple centers in India as well as abroad. Dr. Dhruv Bibra sir is DNB anesthesia from Batra Hospital. He did a fellowship in international pain medicine from Escular Academy, Germany. Then he was awarded fellowship in international pain practice procedures, that is FIPP, from World Institute of Pain, USA, and EDPM, that is the European Diploma in Pain Medicine from AFIC in 2022. He is a very renowned speaker in various pain conferences, both in India and internationally. So we welcome Dr. Dhruv sir. Over you to sir.
Thank you so much, Dr. Sanjeev, for a warm and kind words. Just I would like to be sure that my can I start sharing? I'll just do a check. Yeah.
You're audible and visible too, sir.
Okay. And my fine.
Your slides are visible, no issue, sir.
Okay. So I'll just do a quick. Fine. So everything fine in order?
Yes, sir. It's fine, sir.
Okay. Thank you so much. So can we start or we need to wait for some more time?
So I think we can start. Then later on, others can join. No issue, sir.
Okay, fine. Okay, fine. Thank you so much for the warm welcome, and thank you so much for giving me giving me this opportunity of interacting with some young, interesting set of doctors practicing chronic pain. So thank you so much, Dr. Sanjeev and the new Academy of Pain Physiatrists, for giving me this opportunity and for giving me this interesting topic. The good thing about these kind of interactions is that it is a small group, so I can be informal. At the same time, we can have more of interaction, more of doubt clearing, and more of sharing of common doubts, some insights, and I can share some experiences, some mistakes that I have made, so that as I always say, that you don't repeat those mistakes and you go ahead and make your own set of mistakes, and then you can share it with your colleagues, and this is how we grow.
Okay, true, sir.
Fine, sir. Thank you so much. So primary headaches. So whenever I interact with the, just give me a second, please. Okay, so whenever I start, and this is a common thing, is that when we talk about headaches, and who, according to you and the audience, I would like the audience to give in the chat box, that do you think that we guys or we doctors who are taking care of chronic pain are the best doctors to do to take care of chronic headache, or it is beyond us, or it is a bad topic for us to discuss? Do you think that we are equipped, or we should be handling these patients? A quick, so that everybody gets warmed up. Anybody would like to? Yeah, chat box, we have one response. Do you think that we should be handling these kind of topics? Okay, somebody says it's a multidisciplinary. Yes. Anybody else? Very good. Anything else? Good. Yes. Cool. So for my friends who have those doubts, that we are here promoting and propagating that we are taking care of chronic pain. And my dear young friends who are starting off their career or who are in the initial part of our careers, chronic pain is not restricted to spine, knee, and shoulder. It is way beyond. And when you among the doctor community raise your hand to take up this challenging field of chronic pain, you cannot be selective. You have to up your game. You have to increase your knowledge. You have to work hard and be well prepared to handle any chronic pain. And headaches, most of them are chronic in nature. So you cannot shy away from them. Therefore, we should take care of chronic headaches, basically chronic primary headaches. I would like to add a few things here also, that we are the best guys to actually handle it. And why I say so? Because when we talk about chronic pain, basic example would be they hunt like a pack of wolves. They are not alone. And we doctors, we as a community of chronic pain physicians are the guys who not only understand pain, but all that pack of wolves. Therefore, we have a pure holistic view and understanding of chronic pain, which somewhere I feel is missing even among neurologists, medicine guys. Therefore, we are the best guys to take care of pain and give in totality. That is point one. Second thing is that during the course also we will be talking about, and most of you would be realizing it that in tough chronic headache patients, there are certain interventions. And who better than us is equipped to do these interventions? When I say about doing these interventions, I'm not restricting just to putting in the needle, but when to put in that needle, how to manage the patient while putting in the needle, and how to take care of the patient once we have put in the needle. Here again, I strongly feel that we are the best people equipped to do it. So with that interesting background, I would like to introduce the topic of chronic primary headaches or primary headaches and what is our perspective. So as I told you, chronic pain is no different from any other chronic pain condition. So that is the one thing. Therefore, the biopsychosocial model, as we call it as, has to be taken care of. I think you would be aware of the biopsychosocial model.
Yes, sir, definitely, sir.
Yeah. Fine. So at the same time, I would just like to give a brief that whenever you are assessing the patient, don't not only talk about the biology, the nociceptive, the neuropathic, the dysfunctional, or whatever is the pathology. Along with that, we also talk about how much it is impacting their psychology. And because of the condition and the impact on the psychology, how much is it impacting their social, interpersonal, professional, sleep, and everything. So, my dear friends, why I'm emphasizing it at the very beginning is that when we talk and discuss about any chronic pain, including chronic headache, our perspective has to be based on this. So what I generally follow is the AAA principle. Firstly, be aware that these things will be there in patient of chronic pain. Second, you should be able to assess it. Unfortunately, there are no investigations which will help us in this regard. Only our good history taking, spending enough time with them holds the key to the success of any sort of management of chronic pain. And chronic headache, I am repeating it, chronic headache is no exception. And once you are aware, once you have assessed, it is no use if you do not act. You have to act according to the patient. customizing it to the core. So based on the age group, based on their quality of life, it has to vary and it has to be customized. Therefore, aware, assess, and act. So now let's start with the topic. Now, one thing is that regarding the classification, good thing about headache is that everything has been classified as with any neurological disorder. This is from Kefalgia. It is an international journal of headache, and most of the classification is just based on this classification. We divide the headaches into two types of headaches, primary and secondary. As with any other condition, secondary means that there is any secondary cause that can be our standard tumor, trauma, infection, or any other condition. And then the primary ones are a patient is having headaches where there is no systemic structural disorder which would be responsible for this headache. And whenever a patient walks into our OPD with headache, the first step and the most important step is to differentiate it. Most of the times we do generally have patients of primary headache coming to us, but that doesn't mean that we won't be encountering secondary headache. So secondary headaches are those patients in which the patient will need a kind of a referral. Now, how do we assess? How do we know that it is primary or secondary? The healing or the entire thing depends on history. So these are certain pointers in history which will give us an idea that we are dealing with secondary disorders. One is the classical systemic symptoms of fever, loss of weight, any systemic illnesses, any neurological headaches associated with any neurological signs, abnormal signs, sudden onset, abrupt, extremes of age group can be because of that. One more important thing is that when you are assessing history, always be aware of, because this is something which I have even also seen in my practices, that the patient might be having a typical character of headache for a very long time. But suddenly in past, say, few days or few months, there has been sudden change in the character. Now, this warrants further investigations, maybe a referral. So even if the patient is coming for a follow-up visit, be aware, be always aware of this and ask the patient, has there been the development of any of these symptoms, or has there been a sudden change in the character of pain, in the sudden increase in the intensity of pain? So be aware of these things to be a complete to have that thing, because a patient will not come directly and say that I have got primary headache. And when you say that I am dealing with headaches, you should be aware of this, but do not be under that impression of, as I called it, upon which God hai kind of a mindset. No, these kind of patients, anything, if you are able to diagnose any of these conditions, do not hesitate to refer to the patient to an appropriate specialty. So primary headaches are migrainous headaches, tension type headaches, migraine with or without aura. Then you have autonomic things, most common being cluster headaches. Then chronic headaches like chronic migraines and hemicrania continua. I have picked up some basic cases which will help us to take the discussion forward. So this is a typical patient who walks into our OPD complaining of headache, which has been there for 3 years in the frontal region of the head. VAS is around 3/10 most of the times. She has a headache 4 to 5 times in a month. She experiences photophobia, but still carries on her with her office work. Headaches last for 40 to 45 minutes usually. She doesn't have nausea, nasal congestion, etc. Gets relief from paracetamol at 650 milligrams per tablet. So apart from Dr. Sanjeev, anybody would like to take the discussion forward? Anybody in the audience? How do you proceed, and what all things you will like to go through? Because Dr. Sanjeev, I know him quite well. He's doing great. So, but I would like to interact with anybody would like to take the discussion forward with this case.
Please, you can unmute yourself and you can chat.
Yeah, it's a total informal thing. You can see that I'm also having my cup of coffee. So anybody would like to interact, say what is your thinking? How would you see? And I'll just build on that discussion. Anybody?
Yeah, you can unmute yourself and you can directly
Yeah, definitely.
You can directly.
This is how I like to function. Da, da, da.
So
Hello.
Yeah, please.
Hello. On basis of history or and just like female working in the IT department, I think it's like tension type headache.
Okay, so let's not jump into the diagnosis first. So first thing is that there are no red flags. We are right, sir?
Yes.
There are, Dr. Akhtar sir, there is no red flag. So we are sure that what we are dealing with is a primary headache, right, sir? I think
Yes,
everybody has, right? So let us
Yes,
start from that part that yes, we are dealing because you might be, as you are quite clear with the diagnosis, but again, just for the discussion. So again, whenever a patient comes to us, whether we are seeing for the first time everything, so there are no red flags. So what we are dealing with primarily is a primary headache.
Okay, sir.
Right? So that is
Yes.
for sure. That is not a secondary component. Now, as sir rightly said that that is one. Second thing, in primary headaches, we talked about 3 headaches. One was sort of migraine, tension type, and third was cluster headaches. So cluster headaches, things like nasal congestion is something we will be discussing about it. That is somewhat classical of cluster headache because it will have autonomic, the bigger term is autonomic symptoms are present or not. So in this patient, the autonomic symptoms are absent. So what we are dealing with probably would be a condition either of tension type or migraine.
Or migraine. Yes.
Right, sir?
Yes, sir.
But it could be both, and I will be touching about it later in my talk from a practical perspective. But she experiences photophobia. Now, whenever there is an aura like photophobia, whenever there is something like photophobia, phonophobia, our diagnosis will be going more towards migraine. Right? But
Yes.
you are absolutely right, sir. It can be tension type headache also. And during the course of the talk, I will be discussing and touching upon the dilemmas that we come across. But because it is more with photophobia, therefore it is going more towards migraine rather than tension type headache.
The duration is very less. I think this is goes to the attention.
Yeah, so that's what I said. So that is it can be both, but because of the presence of photophobia and phonophobia, it is more towards that. But yeah, because again, it is about frontal region. So it is not unilateral, bilateral. So this is again a true picture. So that is one thing.
Yes.
Right. Again, thank you so much for giving me that encouragement that we have a good, lively audience. Anybody would like
Thank
to?
you.
So thank you so much. So this is about migraine, as sir rightly said. So it is a primary headache, high prevalence, economic, personal impacts are there. The third most common is basically headache, and it's got a lot of disability. Now, IC International Headache, when we talk about the classification, so they talked about migraine with aura and without aura. So this is a classical definition. You can get it anywhere. So it talks about 5 attacks having criteria from B to D. Headaches lasting for 4 to 72 hours. Dr. Akhtar did point out about it that the headaches are lasting less. So that is one. Second is that migraine generally is unilateral, pulsatile in nature, moderate to severe, and aggravated by physical activities. That is one. 2 out of these 4 characteristics. Second would be during the headache, there is nausea, vomiting, or photophobia, phonophobia. Now, if these are present, then it goes migraine without aura. Just to add it up, if there are aura, which can be visual, sensory, motor, and all those things, then it can be migraine with aura. Now, the interesting thing which every classification talks about is where I tend to differ and on a very practical front is the point number E, not better accounted by any other thing. So it makes a job a little bit difficult because they say that it is, though this is the criteria, but there should not be anything else supporting it. So that way, but generally migraine is unilateral. Migraine is moderate to severe in nature, pulsating, and has nausea and photophobia and phonophobia. Now, when we come to managing these patients, so this is interesting. There, it generally has 4 phases: prodrome, aura, headache, and postdrome. This is for patients of migraine who have with aura migraine. Patients who have aura without migraine, in this the aura phase would be absent. So they have a prodrome, headache, and postdrome. Now, why prodrome is important? I tell you one thing. When I am managing my patients, I specifically ask about, do you get a feeling that you are going to have an headache? Now, this is extremely important because when I see my patient, when I talk about managing these patients, when I talk about abortive treatment, now the abortive treatment has to be started as soon as the patient gets these prodromal symptoms. Therefore, prodromal symptoms are extremely important to identify and make the patient aware that this is the time when he or she needs to take the prophylactic treatment. These are the different types of aura. With regards to aura, you just need to reassure the patient that don't worry, these things will gradually settle down. Now the triggers. Extremely important. These are triggers. Now these are, unfortunately, migraine or tension type headaches or headaches are more of a lifestyle thing right now. So there are a lot of triggers, whether it is sleep irregularities, whether it is exposure to sunlight, whether there is nutritional deficiencies, whether there are certain food triggers, whether there are stress related, hormonal changes, weather changes, smell, light, electronic goods, you name it, and there is a trigger. So what we have done at our center is that we have prepared these 2 lists. So we tell them that it is not a comprehensive list. This is something that we have, this is based on what we have read and what data has been experienced by our patients. So just try to find out which among them are your triggers and work accordingly. But emphasizing the importance of triggers is extremely important if you want any of your management to be successful, whether it is pharmacological management or interventional management. Because if the triggers are not taken care of, then unfortunately all your management is going to fail. So have these things in your clinic, it becomes handy. Okay. Now coming to the discussion that me and Dr. Akhtar were having, is this enough to diagnose migraine? Now, interestingly, I personally feel, and everybody who is practicing, is there is not a single criteria which is sufficient. Because as sometimes aura may be present, sometimes aura may not be present, sometimes nausea with vomiting is present, sometimes nausea plus vomiting is present, sometimes the pulsatile nature of the pain is not present, sometimes it is a bilateral symptoms. So all these things are actually present. So therefore, as I always say, migraine has not read this definition, we have read it. Therefore, be clinically aware whenever you are trying to manage these patients. Therefore, recurring moderate to severe intensity headache should be taken as migraine unless proven otherwise. Only differentiating factor which I always take into consideration is generally if it is a unilateral headache, which is moderate to severe, my diagnosis will go more towards migraine rather than tension type headache. Tension type headache are generally bilateral, and the classical word that we often use is दर्द होता है कि दुखन होती है. Is there a pain or an ache? So if they have an headache, dukhta hai, so it is more towards tension type headache. Whereas if there is a severe headache, severe head pain, unilateral, then my diagnosis is more towards migraine. How would you like to evaluate? Anybody would you like, in a case of migraine, is there any role of any investigations like MRI, CT?
Yes, sir. Eye checkup should be done.
Very good. Anything else? ठीक है. But see, again, these things is something that you will like to ask in the history, right? Whether the patient is having any visual disturbances or not. That is point number one when we talk about visual. Second would be, again, in tension type headache where the symptoms are bilateral, there it is more of an ophthalmic consideration. But if it is a unilateral thing, that is there. But any investigations per se? There is no role of any investigations if it is a case of primary headache and if you have taken your history properly. You go for investigations if there are any red flags that we have already discussed. Now, treatment of an acute attack. Now, what is the criteria? The first thing is that there are two types of treatment. One is a treatment of an acute attack, which we call it as an abortive attack, abortive treatment. Second is a prophylactic treatment. For all the structure, for all the guidelines, they say that if it is less than 4 per month, I repeat, less than 4 per month, in that scenario, you will just go for an SOS on an abortive treatment. If there are 4 or more than 4 attacks per month, in that scenario, you will go for a prophylactic treatment. For an abortive treatment, the drugs that we are use are the triptans. These are the standard line drugs which we are doing. You can even consider going for simple analgesics, acetaminophen and NSAIDs. Initially, we were using ergotamines. Some people might be using, but maximum experience that I have is of triptans and NSAIDs and sometimes acetaminophen. Keep it simple. So, for example, if the patient comes to me and says that whenever I get an attack, I take acetaminophen, a simple crocin, I'm more than happy. Importance is the timing of having this abortive treatment. So, for the timing is as soon as they get their prodromal symptoms. This has to be emphasized to the patient. Jaise hi lage, the moment you get a feeling that now there is going to be headache. That is why in a patient, I ask them to have first always a pair of sunglasses in their bag, because sunlight is one of the most common triggers for headache and migraine. Second, always have an apple, a fruit, or simple Glucon-D biscuits. That is one. Something like a coffee bite, which is sugar and coffee. And their SOS abortive treatment drug always with them. Whenever they get that prodromal symptoms, that is the time that they need to have that prophylactic treatment. Don't let it go climb up, then you introduce and then it goes. It takes time and it improves functionality. So these are the few first aid box, first aid thing that a person should always carry. Okay, these are the drugs. You can go through it. The interesting thing is for triptans, there is a condition which is called medication overuse headache, which is quite common. So you need to tell them that it is for abortive treatment, that if you are having every week or every 5 days, then probably you need to go for a prophylactic treatment rather than an abortive treatment. Okay, preventive therapy, as I told you, 4 is the arbitrary thing. Second, if you think that the patient is going towards medication overuse, using it every week or once in 5 days, the patient has started developing side effects. There is an impact on the quality of life, and sometimes the patient wants this drug because what they are doing is say that one attack, even if I take an abortive treatment, my days are what you say, gets wasted, a couple of hours get wasted, my functionality is compromised. In that subset of patients, they said that we want to have it regularly. I said, go ahead. Only thing that you need to emphasize is that if you are going for an prophylactic treatment, preventive treatment, in that case, the patient needs to have it for 3 months, 3 to 4 months, once there is an effect. So once the patient stabilizes, there is an appreciable VAS difference, improved functionality, then you gradually ask them to go on for 3 to 6 months. There is not much literature about it, but empirically, we go for at least 3 to 6 months of preventive therapy in a very stable patient. What are the drugs? Since the etiology itself of migraine is very interesting, every couple of years it changes. So there are the drugs which are obviously being changed. So one is definitely a beta blockers. Then there is topiramate, which is an anticonvulsant, diproxium sodium, again, which is an anticonvulsant. So that is an interesting group of drugs that we are using. How long? 3 months. Okay. Now, these are certain practical tips with these patients. Now, first thing, this goes with for any chronic pain patients if you are putting the patient on any pharmacology. See, these are drugs which have certain side effects, like sedations, and which we have discussed. So whenever you are giving these drugs, always start with a lower dose. Let the patient be comfortable about it and gradually increase it. Always, I have seen some doctors not prescribing abortive treatment. So prophylactic treatment or the abortive treatment will go on, will be co-prescribed. So you will have an SOS medicine, which they are need to have it whenever they feel that there is increased pain. And then they need to have a preventive therapy, which will be continued as per need. Avoid obviously analgesic overuse and compliance and assessment. Now, this is again 32-year-old male. Now she has daily headaches. Global headaches past 6 months. Initially, there were occasional increased exacerbation. Now she has virtually nausea, unilateral headache for more than 4 hours plus. So what we are basically dealing with is chronic migraine. Now, there are certain risk factors for chronic migraine, which can be caffeine, obesity, depression, other psychological disturbances. And as I told you, the chronic migraine has a lot of, what you say, coexistence, or it can combine with other chronic pain conditions like back pain, neck pain, arthritis. And as I told you, medication overuse also is one of the causes. So this is the definition in which they say it is defined as a headache of more than 15 days per month, more than 3 months, and among those 15 days or more in a month, the predominating symptoms resemble that of migraine. But as I told you that in clinical practice, it is not always like this. So basically what I ask my patient is that, do you have pain most of the days in a month? And then interesting thing is two things. One, they say that I have pain, which is virtually almost all the month throughout. That is one. Second thing is that there is a baseline pain and then there are acute exacerbations. So their baseline, that is why quantifying pain is extremely important. The normal VAS, which I always say is, so what is your normal baseline VAS? They will say my normal baseline base is say 3. Exacerbation goes up to 6 to 8. So those are 7. There is a baseline and then there are exacerbation. These is classical of migraine. So what do we do whenever we are dealing with chronic migraine or chronic headaches with features of migraine? Even for sometimes, though not FDA approved, but patients even have chronic, chronic headaches, which are resembling tension type. Then also we are giving botulinum toxin. It is not a cure. So how do we do it? So we follow a preempt protocol in which we are injecting 5 international units at 31 sites. My friends who are using botulinum toxin for various conditions, they will say, doc, there are two vials, 50 and 100. So what happens to the next 45? So what is the preempt protocol talks about is that you are injecting in the 31 sites. Remaining 45, you follow the pain. What we mean by following the pain is that wherever you feel that there is more pain, you inject more. And probably during the end of the discussion, if we have time, I'll talk a length about more. So for example, if the patient have more of temporal headaches, so we will be injecting something more here. These are the 31 sites where we need to inject. How long does the effect last? Normally, you need to understand whenever we are doing this, we are trying to break the pain cycle. Can we repeat it? Yes, you can, but there is a time interval based on the botulinum toxin that you are using. The first generation botulinum toxin like Botox, there you cannot repeat it earlier than 3 months, whereas the second generation Botox botulinum toxin like Xeomin, you can use it in, say, after 6 weeks. Advise after injection, anything and everything that they can do. Only thing is active rubbing, applying of cosmetics should not be done. Pregnancies, we have not used it. I have put up specific slides for the drugs which can be used during pregnancy. When do we stop the treatment? Once the patient is giving us good relief, and from chronic migraine, it has shifted on to the other thing. Prophylactic medicines, yes, they need to be continued, but gradually they will stop. So this has been our experience. What we have been able to achieve is that it has been effective in around 60% of the patients, in which the VAS went down, VAS went down to less than 3. The duration pain relief was 4.5. Now here I would like to give my perspective, and which even supported by data, is that firstly, what we are trying to do is we are trying to break the pain cycle. Secondly, we are trying to reduce the consumption of medicines when we are injecting botulinum toxin. Third, whenever the patient's pain comes back again, the intensity is way lesser. That is one. Fourth, the thing is you can, so after a repeated, say, three set of injections every 4 or 5 months, the intensity actually gradually comes down. Their consumption of abortive drugs as well as prophylactic drugs also comes down dramatically. Few tips, I will be rushing through it. I think there is, what do you say? I'm quite gone. I'm might be lagging behind. But so when we talk about botulinum toxin, it comes in a vacuum dried vial. The diluent is normal saline. We generally mix it. You can store it for 24 hours. I tend to use it as soon as it is reconstituted. The mathematics is simple. 100 units, put 4 ml of normal saline. 1 ml will have 25 international units. We take it in a 1 ml syringe. So 1 ml syringe. So one division will have 2.5 international IU. So we need to inject 5. So we will be taking 2 division of this. You can have your own formulation. If you want, we can discuss it once after the talk. Now, the interesting thing is that people who, I think you would be injecting botulinum toxin on a regular basis. Now, the challenge is injecting in the right set of muscles. With regarding to face, it is not a major issue because these are small muscles. These are single layer muscles, so you can directly inject it. It is absolutely safe. I repeat, it is absolutely safe. Only thing, when you are giving it for migraine, you need to avoid certain muscles. So for example, if you are injecting into the frontalis, you should not inject in the orbicularis oculi. Now, these are certain things which so this is how we identify the muscle. We ask the patient to contract. This is the gold standard. So this is small tricks. This is for frontalis. The same can be done something like this for procellis. Then this is for temporaris. We ask the patient to clench their teeth, place an imaginary coin, and we inject around the coin, around 20-25 units. So we are injecting at 4 to 5 spots. So these are small tricks by which you can inject. So this is about the treatment. Now this is something which Dr. Akhtar had discussed about headaches which are band in like distribution. Now this is called as the tension type headache. Now, I would like, what is the tension here we are talking about? Anybody else apart from Dr. Sanjeev and Dr. Akhtar? What is the tension that we are talking about here? Mental tension? Anybody?
Sleep
No,
deprivation.
Dr. Sanjeev, nahi, not you, sir. Anybody else? I need to interact with the...
Sir, I am not Dr. Sanjay, I am Dr. Ramveer, sir.
Yes, sir, please, sir. Sorry.
Yes, sir. Sir, sleep deprivation.
Nahi, what is the tension that we are talking about?
What is the meaning of this word tension?
किसका tension है? Mental tension है?
Yes, sir.
Anybody else would like to what would be the house like to agree, disagree with Dr.
Dr. Sankha has written a pulling force. You are partially right. Dr. Nagma has written a band like tension.
Stretch, that is fine. So stretch, strain. What is the tension? Because this is something interesting whenever I interact. What is the tension we are talking about? Mental tension है. EMI की tension, patient नहीं आया तो उसकी tension, patient के साथ complication हो गया उसकी tension है ये. So my dear friends, it is basically the muscle tension that we, yes, exactly. Dr. Rash.
Dr. Mamta June, tightness of muscle.
Yes, perfect. Dr. Mamta, you are absolutely right. The tension that we are here trying to address is nothing but a muscle tension. But as I told and as I discussed also, now this is something which is going to be there, which is common with migraine. Only thing is that classically it is a more of a bilateral distribution. Whereas this is the photograph itself is quite explanatory, where you have a band-like sensation across the head. It is a tension type headache. The diagnostic criteria is 30 minutes to 7 days, so it can be there for a long time. There it was unilateral, here it is bilateral. Second, it was pulsatile, here it is non-pulsatile. Third, it was associated with phonophobia. Here it is not there. There it was increasing with physical activity. Here it is not increasing with physical activity. Migraine is associated with nausea, vomiting. Here it is not associated with nausea, vomiting. So there is a stark difference when we look at when you look at the definition, but from a very practical standpoint, it is very close as a diagnosis. The only thing is the intensity and the functionality. So the patient having migraine will be more functionally impaired versus a patient who is having tension type headache will be able to carry on with their daily activities. So this is when we less than 1 per day, 1 to 14 per days, and more than 15 days per month. So this is the definition. So now that is one thing we talked about. Second thing is, because there is muscle tightness, and everybody would realize that whenever there is muscle tightness for a very long time, there is bound to be some trigger points, some tender points which might be there. Therefore, whenever you examine the patient of migraine or tension type headache or primary headache for a long time, for that condition, do not hesitate to palpate them. So when you are palpating these patients, the muscles that you will see, there will be a lot of trigger or tender points. And interestingly, whenever you have trigger or tender points, what do? You simply inject. So in tension type headache, there is definitely a role of trigger point injections. Regarding medicines, somebody talked about sleep. Yes. So in that case, the gold standard which works for these kind of patients is amitriptyline. Now, amitriptyline, as we all know, is a drug which induces certain amount of sleep. It has the largest amount of evidence when it comes down to tension type of headache. So so that is one. Then, because it is muscle tightness, there is role of muscle relaxants as well. Tinazidine, being a good muscle relaxant, does cause a slight amount of sedation, is also one thing. Regarding botulinum toxin, now when we talk about the literature clearly specifies that botulinum toxin is effective only in patients of chronic migraine. But on a practical note, if the patient is having chronic headache, which is not responding to medicines, impairing their day-to-day quality of life, and features which, as I said, the clinical picture will be mixed, but they have predominance of, say, a tension type headache, I wouldn't hesitate to try a single dose of botulinum toxin. You can tell the patient that, yes, I'm going to do it. And most of the times what I have seen is that, yes, they do respond to it. But if you talk about clinical evidence, specifically in patients of chronic tension type headache, unfortunately, we do not, but there is no harm in trying. So what other thing that you can try? You can definitely try these trigger point injections based on the symptoms. So we generally, as with any trigger point injections, you can consider going for it. Local pus steroids, generally you can just give preservative-free local anesthetics of your choice. We generally go for bupivacaine. If the patient gives us a response, so it is not generally what you should, a single shot. So it is generally a series of injections. So we go for 5 to 7 with increased time interval. So it generally starts with twice or maybe twice a week. Then we increase it to once a week. So that is an entire schedule to just take care of the trigger or the tender points which have developed. Now, this is the third not so common type of primary headache, in which classically the first is that there is severe headache, totally incapacitating the patient. Interestingly, even they have a typical cyclical appearance, typical season, being absolutely fine in between the periods, and having a lot of autonomic symptoms like tearing in the eyes, running nose, nasal congestion, severe headache, having some sort of a pattern, some cyclic, what do you say, cyclic pattern in their occurrence, with absolutely pain-free period for a time, and it comes in the attack. These are classical of cluster headaches, or the other term is trigeminal causalgia. So this is a clustered type of a headache. This is one of the headaches which is more common in men rather than women. When we talk about tension type headache or migraine, this is more common in females. So what do we do? The easiest. So it is like, these are the classical thing: excruciating pain, stabbing, boring, burning, hot poker in the eye, always one-sided. So what do we do? The easiest thing is to give them oxygen, 100% oxygen. It works for them. The second thing is we can go a nasal approach for a sphenopalatine ganglion block. The third thing would be if the patient is having recurrent conditions, in that condition, we can consider going for a radiofrequency ablation of the sphenopalatine ganglion. So this is there. What happens is we go for sphenopalatine block, successful, we can go for a radiofrequency ablation. Now, sphenopalatine ganglion, most of the times it won't be needed. The patient will be managed with medicines, but sometimes, or the extranasal approach. Most of the time we even tell our patients that, okay, these are the things. If you feel that there is a lot of pain, and sometimes what happens is the attack is so severe the patient cannot come to the hospital. So what we ask them is just to use a hair plucker, put a small gauze piece, soak it in local anesthetic and insert it. It's a very raw way of taking care of their pain, but sometimes in remote areas, that is one thing. Second is you can always ask them to go for oxygen. So this we have discussed about it. So throbbing headache, dull tightness, severe ocular pain with these typical characteristics helps us to differentiate regarding these primary headaches. A small subset I will just be touching upon would be an occipital nerve block, or for occipital headaches. Now, occipital headaches, that can be either coming from the facet or they can be occipital neuralgias. As with any intrapid neuralgias, if you give an occipital nerve block, the patient has relief, then what we are dealing with an occipital neuralgia. Then there can be sometimes in the occipital region pain coming from the cervical facets also. So whether it is with regards to occipital neuralgias or with a facetogenic pain, you need to block, give a diagnostic block. Now here again, I would request people who are starting off, they are not, sometimes I've seen them not confident and always asking, sir, ye hoga ki nahi? See, the thing is, do not hesitate to give a diagnostic block. Do not hesitate to give a diagnostic block. Be very honest to the patient that there are no clinical tests which points that there are no investigations based on your history, based on my clinical examination. I feel the source of your pain is an irritation or a blockade or a damage happening onto your occipital nerve. Let me go ahead and block it. If it works for you, then we are sure. And when you are giving a diagnostic block, be ready to fail. Don't be an egoistic person saying that I did a block and it is going to work. You will fail in 50% of the patients, followed by a block. I won't be going into the details of it, but yeah, that can always be discussed. If you feel it, we can even ablate it by radio frequency or sometimes with alcohol. Now, this is something which I thought would be useful for all of us. When we talk about what are the drugs in pregnant females, you can always, so for example, you can consider consulting a gynecologist on an obstetrician when you are talking about it. Discussing a pharmacological plan for it. Paracetamol is more or less safe. Triptans, again, there is no, during lactation, it is definitely safe. Rest, during this entire cycle of conception, first and second trimester, there is no evidence where there increases the risk. So there is nothing for nor against. Again, NSAIDs, we all know that there is an increase in the, see, safest would be the second trimester. Third trimester would be a big no. Rest you can consider in lactation, definitely you can give. But otherwise in first, when they are in the reproductive age group and first trimester, consider avoiding it because there are misconceptions, chances of misconceptions are there. With regards to the preventive treatment, beta blockers definitely are good, except in the third trimester. Again, tricyclic, better to avoid it. Honestly speaking, during lactation, maybe during they're planning a family, yes, but rest, the thing is better to avoid. Anti-epileptics, a big no in in the reproductive age group if they are planning for a baby. I'll just give a few words with a new kid on the block, the CGRP antagonists, a big thing coming up in a huge thing. Cost is a factor. Personally, I have not used it. And if somebody in the audience has used it, I will be more than happy to hear their experience. When we talk about CGRP, new molecule, it releases, has some role in headaches. People have worked, what do you say? There is evidence which talks about using them in chronic migraine, sometimes in acute migraine, not leading them into chronic migraine. What are the mechanism of action? Some there are antibodies acting against CGRP directly. Some are working on the receptors. Some are receptor agonist also. So these are the things which are available. Now we talked about the biopsychosocial factors, but how do we follow it? Do we need to follow it? Yes, we definitely need to follow it. Trust me, with a decent amount of experience and decent amount of failures, your botulinum toxin, your radio frequency, your any intervention is bound to fail if you do not take care of the behavioral or the psychological aspects. CBT, ACT, mindfulness, this is something that you should be aware, and you should also be, you make your patient aware and be comfortable. Ideally speaking, you should have one of the psychologists within your framework. This is one thing which separates us from the neurologists, but yeah. So I think that would be end, but now this is an open house. Did we miss anything with regards to headaches?
Any
Anybody?
comments? Any comments from the audience?
Yes. Did we miss anything with regards to managing? Any intervention, any drug, anything?
Sir, any local gel like overon gel, these have any effect in primary headache like tension type headache or
कर सकते हो, sir.
migraine?
You can try. But go for a funner. It is on the lighter note. It will bring a smile on your face. So don't think too academic. Though it is coming from an academic source, but think out of the box. We can have a little bit of fun on a Saturday night.
Hello, sir.
Hanji, please, Dr. Sahu.
How would we choose the prophylactic medicines?
I'll tell you, but first answer this, sir. If there is anything else that you can suggest your patient
For what, sir? This
for
migraine?
headache, for migraine, and for tension type headache.
For migraine, also tension type headache, some exercises usually I prescribe as a
Arey,
physiatrist.
sir, light up. We will get into the
And,
academic discussion. I'm not in a hurry. थोड़ा सा light up
so-
करो. सोचो क्या कर सकते हो, suggest.
I would
So
say
usually
I-
along with all this, I suggest some exercises like
ठीक
No,
है,
no,
done.
no.
और कुछ?
cardiac training, like and the breathing exercises and the stretching programs.
अरे
That
sir,
usually
ठीक है,
help
चलो.
and
और
I-
कुछ? We will talk about it all.
शाम को बैठते हैं चाय पे चर्चा करते हैं
Something on those lines.
शाम को बैठते हैं
Anything else? Anybody else, यार? थोड़ा तो light up कर सकते हैं. See, this is it. It is from Kefalgia, 2013 studies,
Okay.
which said that yes, in patients of migraine, some sort of a sexual activity can actually help you relieve pain. Right? Cheap, easy, and effective. Not so much in cluster headache, in tension type headache, but yes, definitely in migraine.
It will release the endorphins and encapsulins, which will.
Yeah, whatever. I have not gone through it. I was just Googling, so I found it. So with that, I would always suggest your take-home message before we open the house for discussion is identification of red flags. Extremely important. Extremely important. Extremely important. Even if the patient is in follow-up for you over years and years together, always identify, be aware of these red flags. Start your discussion with that. Identification of yellow flags. Again, it will help you prognosticate and manage your drugs. Intervention should be used, and botulinum toxin is safe and most evidence-backed. So please do not hesitate to use it. Now the house is open for discussion. So somebody talked about choosing the prophylactic treatment. So sir, whenever I talk about prophylactic treatment, I generally ask few things that if the patient is having more of palpitation, घबराहट बेचैनी होती है कि नहीं, then in that case, I will like to go for beta blockers. But otherwise, I would like to go for topiramate. Right?
So
With
what
only
is
thing,
what is your experience on with this amitriptyline in migraine, chronic migraine cases for prophylactic treatment?
very good question, Dr. Sanjeev. So if the patient is having sleep disturbances,
Yes.
then I do not mind adding a little bit of TCAs with my drug, with my choice of drug. See, I tell you on a very practical front, though it is very good to have an academic discussion, it is migraine and this. So patients who generally turn up to us, because we also realize that we are not the first, very rarely will you come across a person who is first time seeing you. So they will make the acute condition chronic. They will have features of chronic migraine as well. They will have features of tension type headache also. So amitriptyline definitely, but again, it will be based on the symptoms and the profile of the patient.
So
Yes, Dr. Sahu, you talked about exercise. Exercise definitely has a role, but what I have seen is that because hypoglycemia is known to precipitate headaches, so what I request my patient is, yes, you should do some sort of an exercise. The best would be something like breathing and relaxation exercises. But if you have to go for strenuous exercise, do not do it empty stomach. Always have something before you do it, because hypoglycemia is something which I have seen is a common thing. I'll tell you one more practical example. Now we have Navratras coming, right? So in Navratras, patients will have, because they will fast, they will have fast, even in that holy month of Ramzan, they will fast and then they will have all migraines. So those are these things. That is why in the first aid kit, you will have to emphasize there has to be either a cap, sunglasses, something like which can give them instant glucose. It can be a Glucon-D biscuit, an apple, or a coffee bite kind of or a candy, and their abortive treatment. You have to emphasize. I make sure कि दिखाओ मुझे, तुम लेकर आए हो ना 15 दिन में कितना है दिखाओ. You have to be so emphasized because see, they are looking for quick, what you say, reliefs. But at the same time, whatever you do, the triggers have to be controlled. These are the most common triggers. So triggers have to be controlled. Then only these things will work. Otherwise, you might go charge 45,000 for your botulinum toxin injection, and it may not work. It might fail, and they will say that you took a 40,000 and it never worked. The triggers have to be put under control. Any other questions, sir?
Dr. Rambir has asked that, sir, why muscle tension develops in tension headache and causes pain, but why not in migraine?
Very good question, sir. बताऊं with regards to pathophysiology, that is still a golgappa. I'll tell you. That is one thing which even I don't know the answer. I'll be very honest to you.
Actually, there are some extracranial causes of this headache. For example, this muscle tension, muscle spasm, and even some nerve irritation. These are the causes which can cause which can precipitate the migraine.
Yes.
And even this can cause the lacking pain, and it will cause the tension headache. So it is a mixed type of things, and very complicated pathophysiology is there. So definitely answer is not easy to say.
Dr. Rambir, I'll just give you a basic example. See, so for example, you have a tricyclic antidepressant as one of the drugs. You have anti-epileptic as one of the drugs. You have a beta blocker, which is a cardiac drug, as one of the drugs. Then you have an NSAID, and now you have CGRP. मतलब सब कुछ ही हो, मतलब if you see, every aspect is covered. And then you have botulinum toxin, which is a neurotoxin. Right? So to be honest, there is nothing which even they know. Everything, if you go into the pathophysiology, every couple of years, it keeps on changing. So pinpointing it is very difficult, to be very honest. But these are the few things that which Dr. Sanjeev has talked about and briefly touched. Those are the things which you can say that, okay, yeah, that might have developed. Fine.
So as we have seen in this trigeminal cephalalgia, there is an involvement of trigeminal complex that is in the B2 complex in this cluster headache.
Yeah.
So this is one of the cause of the cluster headache. So even we can go for trigeminal interventions.
Yes.
And sphenopalatine ganglion neurolysis, this nerve block and the RFA works in these cases.
Definitely.
So one of the questions from Dr. Aradhana. So nowadays we are coming across usage of Botox for trigeminal neuralgia. Your views about this?
I have not used it, but there are neurologists who are doing it. I'll be very honest. I have interacted with few of the neurologists who are doing it, but frankly, I have not used it. I generally prefer going for a ablative procedure of the nerve, whether I go for peripheral nerve blocks or a radio frequency ablation. That is something which I am more comfortable and more experienced.
I have read a few articles regarding use of Botox for the trigeminal neuralgia. They are giving to this supraorbital nerve, infraorbital mental nerve, or auriculotemporal nerve. So local nerve block can be given by the use of Botox. So that is the thing.
Yeah, see, again, I'll tell you, Dr. Anuradha, see, again, I think most of us work in a private setup, right? So the cost effectiveness also has to be looked into. So for example, if the amount that we would be injecting here, the amount of the costing would come out to be same as radio frequency ablation. So that is why you will have to compare what you want to do and what you don't want to do. So rather than if you're in an academic institute, yes, you can consider going for a botulinum toxin. But if you go for a standard company botulinum toxin versus a radio frequency ablation, the costing, everything has to be taken into consideration before we suggest something. But I don't have an experience, so I'm probably not the right person. But as Dr. Sanjeev said, there are studies which talk about, and I have interacted with few of the neurologists who are going because they are not comfortable doing invasive interventions.
So Dr. Aradhana is asking another question that patients having dysesthesias across the trigeminal nerve distribution, but not pain. Then what drugs would you prefer, and if any modality, which one? Dysesthesias in trigeminal nerve distribution.
See, the thing is, again, so dysesthesia whatever is an so what we are dealing with is something like a neuropathic condition. So in that, if there is a neuropathic condition, now there are two things. One is a standard newspic based guidelines, which talks about tricyclic antidepressants, SNRIs, alpha to delta ligands. These are first line. You can use any one of them. That is one. Second thing is, what we have found out is, though not too much of evidence, but even in that literature, is the use of carbamazepine in any orofacial pain. So from a very practical standpoint, whenever I have a pain which involves the head and neck region, basically the face, the neck and everything, I would like to go for a dose of carbamazepine. In this case, pure carbamazepine, no NSAIDs, no weak opioids also. Pure carbamazepine, do it and see how the patient is responding. That is one thing. Second thing is, sometimes people talk about that there is just an abnormal sensation. Should I go ahead and block the nerve? I won't be so comfortable doing it. I'll tell you why. Because what happens is, it is not the pain which is troubling him, it is an altered sensation which is troubling him. So the moment you give a block, you are replacing one abnormal sensation with another abnormal sensation. And I have seen it in patients specifically of herpes, which is associated with abnormal sensation, that we land up in a bigger problem. So we have replaced one sensation with another sensation, and the patient is after us ki doctor pehle ye wali kam thi, ye kharab hai. So if there is any abnormal sensation, stay away from putting in a needle. Try to manage the patient conservatively.
Dr. Samantak is asking, I think he's commenting that nasal and paranasal pathologies are also common and may cause little headache. So these are things which you should always ask in history, whether the patient is suffering from nasal stuffiness or other features. You should always ask. For example, if the patient has a history of deviated nasal septum,
Yes.
all these things you have to ask. Recurrent this coryza or running nose or stuffy nose. Already
Please, see, the thing is, that's what I told. Don't suffer from this phenomena of Apunich God kind of a thing. We do not hesitate to refer the patient to an ENT guy who is an expert in this. People, though you can get a feeling that, okay, this might be a reason, that might be a reason. So get himself examined. They will be able to give you will also be sure about it. Otherwise, basic point is, firstly, you should be able to help your patient. Second thing is, your treatment should not fail. So for that, if you need to refer these patients to the concerned specialty, do not hesitate. We are experts and we are best equipped to handle primary pain conditions. Let's stick to our specialty and be honest with our patients.
So to summarize this talk, first of all, if in any headache case, first of all, we should differentiate whether it is a primary headache or secondary headache. Always see for the red flags. After primary headache, you can classify the headache into migrainous headache and other types of headache depending upon the clinical features. First of all, try the medical management, but if it is not working, then you can go for interventions. Interventions can range from the nerve blocks to radiofrequency ablation, and now there's a new treatment like occipital nerve neuromodulation or transcranial magnetic stimulation are there, which have some studies have shown that very good effect. So these all you can do. So thank you all. I think that there are no questions left. So I would like to thank our speaker, Dr. Dhruv Bibra, for his excellent talk. Always, his talk is always excellent to listen, and we always learn from him. So thank you all for this.
Thank you. Take care.
Okay.
Right.
Okay. Good night, sir. Good night.
Good day.
Good night, everyone.
Bye.
Good night.
Bye.